Hello and welcome, everyone. Welcome to the Healthcare and the ADA Inclusion of Persons with Disabilities webinar series. My name is Katie Warden, and I'm here today with John Doris from the Northwest ADA Center, and we'll be your moderators for today's webinar. This series of webinars is brought to you by the Pacific ADA Center on behalf of the ADA National Network. The ADA National Network is made up of 10 regional centers that are federally funded to provide training, information, and technical assistance on the Americans with Disabilities Act. You can reach your regional ADA center by dialing 1-800-949-4232. Next slide, please. Captioning. Real-time captioning is provided for this webinar. The caption screen can be accessed by choosing the closed caption icon in the meeting control toolbar. So this webinar series is intended to share issues and promising practices in healthcare accessibility for people with disabilities. The series topics cover physical accessibility, effective communication, and reasonable modifications of policy under the Americans with Disabilities Act. These webinars occur every other month on the fourth Thursday at 2:30 p.m. Eastern, 1:30 p.m. Central Time, 12:30 p.m. Mountain Time, that's where I'm at, and 11:30 a.m. Pacific Time. By being here, you're on the list to receive notices for future webinars in this series. The notices go out about 4 weeks before the next webinar and open that webinar to registration. Next slide, please. So listening to the webinar. If you do not have sound capabilities on your computer or prefer to listen by phone, you can dial 1-669-900-9128 or 1-646-558-8656. Oh, I hope I said those numbers correctly. And our webinar ID is 098-0604-7881. And it's important to know that this is not a toll-free number. Okay, next slide, please. At the conclusion of today's presentation, there will be an opportunity for everyone to ask questions. You may submit your questions using the chat area within the webinar platform. The speakers and I and John will address them at the end of each section. So please feel free to submit your questions as they come up during the presentation. So on the slide, we have more information about submitting questions. So you may type and submit questions in the chat area text box or press Alt-H and enter text in the chat area. If you are listening by phone and not logged into the webinar, you may ask questions by emailing them to adatech, TECH, at adapacific.org. Next slide, please. Technical assistance. If you experience any technical difficulties during the webinar, send a private chat message to the host by typing in the chat window. Type your comment in the text box and press enter. Or you can email adatech@adapacific.org. Or you can call 510-831-6714. Okay, next slide, please. Great. So today's ADA National Network Learning session is titled Tools and Resources to Promote Healthcare Access for Individuals with Intellectual and Developmental Disabilities. This webinar will explore barriers people with intellectual and developmental disabilities encounter in accessing healthcare services, and some best practices that providers can adopt to better serve this population. The speakers will share some themes from their recent interviews and surveys of people with IDD, caregivers, and practitioners. They will also share a recent tool they created to help healthcare providers assess their inclusiveness and create a customized action plan to address disparities. So let me introduce today's speakers. So today's speakers are Dr. Brenda A. Leith, who is a biomedical ethicist and health policy strategist, who serves as the executive director of the Center to Advance Community Health and Equity at the Public Health Institute. She spearheads transformative initiatives that catalyze systemic change in pursuit of health equity. With a distinguished 30-year career, she has earned prestigious appointments, held executive leadership roles, and received recognition across the public and private sectors for her contributions to advance health equity. Our second speaker is Jerry Davison. Jerry is the director of the Center on Disability and the Pacific ADA Center, both housed at the Public Health Institute. Jerry has spent her career in the disability rights field. Jerry's areas of expertise include Olmstead and the Americans with Disabilities Act integration mandate, the overuse of guardianship, go Jerry, and employment and healthcare access for individuals with disabilities. As a person with psychiatric disabilities, Jerry is passionate about the importance of people with disabilities leading the way in developing any policies or practices that impact them. I will now turn it over to our speakers.
Next slide. Yeah, thank you, Katie. So I'm going to just start us off. Today, we're going to be talking about tools and resources to promote healthcare access for individuals with intellectual and developmental disabilities. This is coming to you on behalf of the Center on Disability, the Center to Advance Community Health and Equity, which is where Brenda works, and then the Special Olympics Health Foundation that funded our project. Next slide, please. And I'm not going to go back into introductions. Katie did a wonderful job doing that. I did want to just say that both Brenda and my program are at the Public Health Institute. We're both centered at the Public Health Institute and run our programs. Next slide, please. About the Center on Disability. So the Center on Disability is a program of the Public Health Institute, like I just said, a nonprofit organization. Our mission is to provide education, advocacy, and support to advance the full and equal participation of people with disabilities in all aspects of society. And an example of some of the services that we provide: training, technical assistance and capacity building, accessibility and compliance services, resource creation, system change and advocacy. And as many of you know, our work with the Pacific ADA Center, that's one of our projects. Next slide, please. And Brenda, I'll let you talk about CASH.
Thank you, Jerry. The Center to Advance Community Health and Equity supports strategic approaches to health improvement in communities where health inequities are concentrated. We engage diverse community stakeholders to tackle complex health challenges and align resources to ensure health for all. Some of our services include consultations, technical assistance, and research. Next slide. So I'm going to start, and I want to walk us through this slide because there are two models that are depicted on this slide in terms of understanding intellectual and developmental disabilities. On the left side is the medical model. This is basically showing various diagnoses or perceived deficits. And when this lens is used, it has a limitation in terms of the number or the prevalence of individuals who have intellectual and developmental disabilities. So if you look at the slide more carefully, you'll see that above the center is autism spectrum disorder. As you go to the right clockwise, you'll see Down syndrome. You'll see speaking or understanding. You'll see fetal alcohol syndrome, learning and applying knowledge, intellectual disability, social cues and relationships, cerebral palsy, and memory functions. These are examples, the darker font color is showing examples of challenges with functioning and participation. The lighter font color is describing conditions associated with IDD, and that's the medical model. On the right side is the social model of understanding IDD, and this is the model that Special Olympics Health embraces. It's a much broader model and it centers on people's rights, their participation, and their potential. So if we start at the top of the center circle, you'll see stigma and negative attitudes. If we go clockwise, you'll see exclusion from planning and decision-making processes. Next, you'll see complex systems for accessing needed services. You'll see transportation as a social barrier, an example of one. You'll see inaccessible written and verbal information, and you'll see strict time constraints in health system. And I wanted to walk through this slide because what I was hoping it would do is to provide context for the next slide, which is talking about prevalence. Next slide. Thank you. Estimated IDD prevalence. This slide is indicating that there are about 7.4 million people in the U.S. who live with an intellectual or developmental disability. And this approximates into 1 in 6 children or 1 to 2% of adults. However, depending on what definition is used, estimates are often upwards to 16 million. Next slide. So I want to focus on what this picture is showing. There is a staircase with people who are walking down the stairs, and then there are people who are in wheelchairs at the bottom in a roundabout. And so the issue here is there's a barrier for the folks who are at the bottom of the stairs to be able to go up or down the stairs to be able to access whatever services there are that are in this building. And so what I'm pointing out here is that there are still lots of gaps in healthcare services for individuals with IDD. There are disparities in access, equity, and patient-centered care. And what I'm wanting to drive home is that there's still an urgent need, despite how long there has been a focus on trying to make improvements for this population. There's still an urgent need for continuous quality improvement that's tailored to the intellectual and developmental disabilities population. Next slide. So from my perspective, there are lots of benefits to serving patients with IDD. First of all, we can avoid complaints and lawsuits if we focus more on compliance with non-discrimination laws. It allows us to provide a medical home for this patient population plus their family members. Then there's the assurance of equitable access to quality services. We can then hope for and move towards improved health outcomes for people with IDD. Certainly, we want to improve person-centered care, and we want to increase social inclusion and social integration. Most of all, I think, well, not most of all, I want to say, in addition, I would say there are cost savings that can be achieved for health systems. Next slide.
I'll jump in here just to talk about the work we're doing, and just to let you all know, we decided to save questions until the end just to make sure we get through everything. You can put them in the chat if you're worried that you'll forget them, and we'll come back to them. About our work. So this is what the Cash Center and the Center on Disability have been working on for the past year or so, is working with Special Olympics Health to create a self-audit tool that medical entities, whether that be doctors' offices or health healthcare centers, hospitals, dental providers, rehab facilities can use to assess how inclusive and accessible their practices are. And so what we did to kind of create this tool is a lot of background research. So one thing we did was an environmental scan of what currently exists. Are there tools out there that are already doing this? Can we pull, some of the stuff that's used in those tools to create ours? And what we found were there were a lot of tools, but there was not anything that was specifically tailored to the IDD population. Some were for people with disabilities in general and didn't really get into specifics on the IDD population that we felt like were necessary. Some of those that were tailored to the IDD population were in countries that don't have the Americans with Disabilities Act. And so we needed something that kind of meshed our laws and requirements with the specific population that we know is being left behind in current practices. So we did along the way, though, find a lot of great resources and tools, and some of those we're going to share with you all today. Some of those will be in the companion guide that goes along with the tool. And I know it was mentioned in the comments, but we had all hopes that the tool was going to be ready today and give you all the link. It is complete. It's just not housed on the Special Olympics website just yet. It will be by early November. And as soon as it is, everyone who has attended this session will get a link to it. But we'll talk about what's in it so you can kind of know what to expect. Also, we did a literature review. So Brenda and one of her consultants did an extensive literature review about what are some evidence-based practices for people with IDD, what are some practices that are showing really positive outcomes, what are some that are showing negative outcomes, and really looked at what we wanted to include in our tool. The biggest thing we did was talk to the people who are most impacted. So we had focus groups with individuals with intellectual and developmental disabilities. We also have focus groups with caregivers, and we talked about what are some barriers that they are encountering. And we also did some key informant interviews with some medical professionals who are out in the field, some researchers who have been doing a lot of good work here. We reached out to a lot of specialists and experts on the subject matter of medical care, specifically for this population, and got a lot of good information there too. We did a site visit to a model, what I would call a model clinic called the Jefferson Fab Center, and in Philadelphia, and took away some best practices from them as well. We did a virtual site visit with a telehealth provider called Station MD, and got some information from them too about their best practices, because they specialize in telehealth for specifically for behavioral health and psychiatric services. And so that was really cool as well. And then we did a large survey for both individuals with intellectual and developmental disabilities and for their caregivers. We did that survey in both English and Spanish, and we were able to take away some of the broader themes from that and pulled out some of the themes. Next slide, please. So here are some of the results. Some of you, this may be, you know this, you may be working with these populations, you may see this in your day-to-day. I've seen some stuff in the chat already that's coming to the host and the panelist about some of the issues. But I do want to go over these, and I typically don't like to read straight from the slides, but I think in this case it's the words of the population that we're trying to serve, so I think it's important. So results of survey and focus groups for the individuals with intellectual and developmental disabilities. Not being able to transfer out of chair to receive a full exam, fast-paced or rushed visit, the medical provider dismissed their concerns, talking to a support person or caregiver instead of directly to the patient. So the provider was communicating directly with someone who was there to assist them and not the patient themselves. A lack of personal interaction. It was difficult to navigate through the office just physically, or difficult to navigate because they couldn't find their way. Next slide, please. Long wait times. So sitting out in the waiting room, the follow-through was placed on the patient with multiple steps, but there was also a lack of follow-through with medical providers regarding refills. So there was having to be reminder calls from the patient. And typically, folks are seeing multiple providers. They may have specialists, and so having to follow up to get the medications you need can be really burdensome for folks. Not understanding forms or a lack of support provided in filling out those forms. Several responses indicated a lack of understanding of the provider's communication, what steps they should be taking next, or what to communicate to their other providers as far as what information may be relevant to share. Several responses discuss the difficulty in retaining information from appointments due to memory or concentration issues. So that showcased a need for maybe both written and verbal communication, or communication to be in plain language or in multiple formats that the person could understand. Next slide, please. Some other responses included being able to use the preferred method of contact. So some folks prefer to communicate via email versus a phone call or a medical portal. And so just asking upfront what may be preferred by the what may be preferred by the patient, and making sure to communicate in their preferred method, and allowing all of those avenues to be acceptable modes of communication. Doctors not listening or fully examining patient, assuming the problem is related to a pre-existing disability. So anytime they were going into their doctor's office, the doctor would automatically tie it back to their pre-existing disability and not necessarily something new that was occurring. Noisy and overwhelming physical environment, transportation and traffic difficulties. Male providers lacked comfort in examining the patient's body. So presumably this was a female patient, and the male provider did not feel comfortable examining the individual's body. Next slide, please. So those responses were from the open-ended questions on the survey. We also had, just some general multiple choice questions as well. These are some pictures from our site visit with the Jefferson Fab Center. I wanted to share and point out a couple of things in these photos. The photo on the left is a picture of Brenda and me with a few of the staff there at the Jefferson Fab Center. We are standing actually in a separate waiting area that they have. The waiting area that would typically be used is shared with multiple providers that share the building, which makes it really convenient for folks to get multiple provider visits in, or pharmacy visit in while they're there. But for folks who can who may not be able to handle the the noise and the busyness of a large waiting room, they are able to bring them back to this waiting room and hold them there, or to take them directly back to a room. The photo on the right shows an exam room that was specifically designed for people with intellectual and developmental disabilities. And I know that not everyone has the budget to do something like this, so I'm not saying that this is to be expected from everyone, but I think it's important to point out what could be a goal for folks. So this room showcases a hospital exam, well, an exam table that can be reclined, so it can be like a bed that you would typically have to be examined on, but you can also sit on it. They also can use this room as a changing space for adults who may need to have their bathroom duties taken care of before or after an appointment. There's a lot of space in the floor. It's a large exam room, so that allows for people to bring support networks, their caregivers, their family members. They can also fit a service animal in there. So there's lots of room to move around in. The lights were able to be dimmed so that it wasn't so overwhelming with the fluorescent lights. And also the rooms had been soundproofed so that if someone did need to express themselves verbally and they were shouting or being loud, then it wouldn't necessarily impact the person in the room next door. Another cool thing that they did was have fidgets and stress balls in the cabinet stored in case someone was feeling a little bit nervous about their appointment. Then they could pull those out and allow the person to use those as a distraction. They also had a lot of portable equipment so that if someone did not want to come into the exam room and the exam room itself was intimidating, they may be able to see them in that private waiting room. They even told us that they had at times seen folks in their vehicles if the service that they needed, was okay to do that for. So they were really trying to work to tailor their services toward the community and the specific needs of that patient. Next slide, please. So once we had done all of this background research, we looked for common themes and we pulled out domains for the specific topic areas that we saw as the biggest areas that providers may want to examine for their self-audit. And then we developed questions for the tool based on all of the things, the interviews that we did, the literature that we read, the sample tools that we had seen to pull from. And then we took that and we created our tool along with a companion guide. So the tool itself is the questions, and you can answer based on what your practice is currently doing or not doing. And then there's a companion guide where each question matches up with some information about that question and gives you resources that you can look to dive a little deeper into that question. So what we did once we had a draft tool was we pilot tested it with a few providers, and then we interviewed them after about their experiences so that we can make revisions, because that's our target audience is medical providers. And so we wanted to make sure we took their input into account and made it as user-friendly as we could for something this extensive. Next slide, please. So the domains that we came up with for the tool are staff training, communication, physical space, operations, policies and procedures, autonomy and support, and specialty areas. There is some overlap. It was quite hard to try and figure out what category some questions fit best in. Another reason why there's some overlap is because we wanted to make sure people were doing it both in practice, but also that it was written down somewhere, so that if one staff member was doing that in practice, but that staff member left the office, then the policies and procedures would be kind of a guiding document that made sure that that practice continued, and vice versa. Just because something is written down as a policy and procedure doesn't mean the staff are actually doing it in practice. So some of those questions may seem a little bit repetitive, but there was a purpose for that. The domain autonomy and support was really just looking at making sure providers were giving the actual person with the intellectual and developmental disability, the opportunity to make their own choices, to decide who their support network was, to make sure that there was person-centered care. Those are the questions that were in that section. And then the specialty areas is a shorter section, but we could have done a whole nother project on that, but that really got into specialty providers. There were some questions that are specific to dental providers there. There's some questions that are specific to facilities that have patients stay overnight and making sure that they are complying with the ADA. There's some specific questions, I believe, to OBGYNs. So that's kind of what that area is. Next slide, please. So to give you some basic tips from each domain, especially since we can't give you the tool today, we did want to just go over some practical advice and pick some of the main takeaways from each of the domains to talk about today and give you some takeaways. Again, we'll be sending out the tool and the companion guide link as soon as it's available, which should be early November. Next slide, please. So under staff training, some of the things that we wanted to make sure providers knew were making sure that all staff that interact with patients have been trained on patients with IDD. We saw a lapse of that training. Well, first of all, we saw a general lapse in medical providers' access to training specifically for the IDD population. That is something that we saw across the board folks are not getting enough of in their medical school curriculum or in their nursing curriculum, in their, whatever their responsibility was. But when we did see providers that had done some training in it, we often saw the front end staff left out of that training. And that's really that first touch that folks with intellectual and developmental disabilities would have. And so making sure your front desk is trained on, do you have accessible exam equipment? Do you have staff who are trained on how to communicate with someone who may have a communication disability? So just thinking through those things. Understanding the social model of disability instead of focusing solely on the medical model. Brenda talked about those earlier in this presentation, but really thinking through how both may be helpful to the patient. Obviously, we need the medical model. Sometimes we go in because we are sick and we need medicine, but thinking through what barriers or challenges that person may face when they go back into an inaccessible community and what services they may need and how they may need to get connected. Knowing the provider's legal obligations under the Americans with Disabilities Act, recognizing informed consent and how to document that, understanding how to read legal documents, such as those for guardianship or conservatorship or power of attorney. Sometimes providers would just take that and assume that the person did not have the capacity to make those decisions for themselves, when in fact, there may be just a limited guardianship, or there may be something in that document that specifies that it doesn't take effect unless this happens. And so it's really important that those documents are read by someone who understands it to make sure that providers are not inadvertently taking someone's rights away. Next slide, please. For communication, this was a big one we saw, even with providers who, our pilot providers were already doing a pretty good job of serving individuals with intellectual and developmental disabilities. That's one of the reasons why they wanted to be pilot sites, because they wanted to make sure they were doing a good job and they really felt passionate about serving this population. But one of the big things that came up time and time again was that they realized that their forms were not in plain language and or easy read. And I'm not going to go into a whole lot of detail about plain language or easy read, but plain language is really about communicating in writing the way you would handle a typical everyday conversation with someone, not using legal jargon, not talking with acronyms, and making sure that it's in typically 6th to 8th grade reading level. Easy read is another level that someone may need if they have an intellectual or developmental or cognitive disability, or maybe they have maybe that Spanish is not their Spanish is their primary language and English is a second language. Easy Read may really help folks with that because it typically has pictures for each line and there's only one idea per sentence, and that's typically a 3rd to 5th grade reading level. And so someone may need a form converted into Easy Read or plain language to make sure that they understand it. Offering information about the visit and the follow-up, information both verbally and in writing. And we talked about that a little before about people not really understanding what they heard in a doctor's appointment. And I know that when I come back from doctor's appointments, I typically think of like questions I could have asked or what I should have remembered to ask. And so I think it's really important to give folks time to process the information, to ask questions, to make sure they understand there are certain communication methods that you can use to make sure the person is understanding the information that you've given. Also communicating directly with the individual when that's appropriate. Alternative forms to communicate. So people with intellectual and developmental disabilities may also have other disabilities, and it may be helpful for them to have information in a different format. So using ASL, large print, pictures, videos, models, all of those things can help explain something that may be scary or intimidating or just complex to a person who may need a little bit of extra information. So thinking about what you can do to make sure that person really understands and is comfortable with where the visit is headed and what procedures or operation is needed. Next slide, please. Physical accessibility. So eliminating mobility barriers and ensuring wheelchair accessibility. This is important to think about, even if you are confident that your facility is ADA compliant and was designed with the ADA in mind. People still mess those things up because they will store boxes in a place that prevents the amount of width in a hallway or a doorway, or people will put a plant somewhere. And so just think about what folks may have done that could have altered the accessibility for a patient who uses a wheelchair. Another thing we see often is that delivery vans will use the accessible parking spaces. And so making sure that folks are educated on that, or staff will use those parking spaces to run quickly in the office to grab something and then come back out. But meanwhile, someone may have needed to park there. So just making sure staff are trained on how to prevent that from happening. Wider doorways, making sure you're thinking about everywhere that person may need to access, not just the main entrance, but the exam rooms, the restrooms, thinking through that. The testing rooms, the check-in height of the desk, making sure someone can see over the desk and has a place where they may need to complete paperwork or be assisted with paperwork. Accessible parking spaces with access aisle and the path to the entrance. So not just the parking spaces, but also, is there a clear path to the entrance? Are there signs directing the person where to go? Equipment that promotes easy transfer from seated or standing positions to exam tables, accessible exam tables. Those are things to think about. Using accessible design and universal design principles. And that's another thing that we're not going to have too much time to get into. We'll talk about it a little bit, but there are more resources in the tool. Next slide, please. As far as operations go, allowing multiple ways to schedule an appointment, allowing for reminder alerts and making sure the language in that reminder alert is easy to understand. A supportive intake, treatment, and follow-up process. So is there someone on staff that can help make sure that person understands all of that process and is there to help support them. Allowing for reasonable modifications to policies and practices when needed. Some of the most common modifications that may be needed for this population are longer appointment times, minimal wait times, and a quiet place to wait. And I know that longer appointment times can be really difficult with how certain insurance policies or Medicaid procedures may allow for billing. That's something that needs to be worked on on a systemic level, and it's definitely something that we are aware of and have been looking into. Supportive referral networks to holistically address physical, emotional, social, and intellectual needs. So for that one, what providers really need to start doing is making a list or a referral go-to list for folks they know are comfortable and well-trained and accepting patients with IDD, which no one should be denying, by the way. That is not something that you can deny a person because of their disability, but we know it does happen. But we also know that not everyone is going to be well-trained with this population and provide the best services. So if you find providers who are really great at serving this population, add them to a referral list that you're collecting so that you know that you are putting them in a good place when you refer them over. Ways to measure patient and caregiver satisfaction. So are you doing that? And are you doing that in a way that is accessible and understandable for the folks that you're serving? And then what are you doing with that data? Are you doing what Brenda referred to earlier, that continuous quality improvement cycle where you're looking at where you may have some barriers and making those changes based on the feedback and the audience that you're serving? Next slide, please. As far as policies and procedures, it really is about getting it in writing so that everyone is on the same page. So making sure that you're complying with legal and ethical standards, and a lot of that is coming from the other sections in the tool. But again, making sure it's written in your policies and procedures. Do you have a designated staff member to handle disability-related concerns and issues? Because that person can make sure that they are well trained and then pass along trainings that may be beneficial to other staff members as well. And that way, folks aren't just handling those as they come in based on who was on staff that day, and people are getting consistent responses to those concerns. Having informed consent policies written down, what that looks like for your medical office, having a reasonable modification or accommodation request policy so that it's clear what folks need to do, and sharing that with new patients, and not just with new patients, sharing that on a regular basis, because as we age or as our disability progresses, things may look different and we may need to change things up to get the support that we need at our doctor's visit. Alternative communication methods, assistance with forms transferring, what does it look like when someone needs transfer assistance? What is the policy on that? Are your staff trained to assist with that? Person-centered policies and practices. So really thinking through that support may look different for each individual. You've met one person with autism, you've met one person with autism. They don't all look the same. You've met one person with cerebral palsy. That may not look the same as another person with cerebral palsy. So just thinking through what that looks like to provide that person-centered practice, and making sure staff are on board and know that that's your commitment to that. Health and safety procedures. So there are some things to think about that may be a little different, and what that may look like. There may be some behavioral issues that come up as there might be with other populations. And so what does that look like, and how is that handled? And are there folks who are trained on how to de-escalate a situation and reassure someone? And just thinking through that. Next slide, please. Autonomy and support. So with dealing with patient autonomy, it's always important to assume competence unless the evidence is clearly pointing in a different direction. And that goes for folks who may not communicate verbally. That goes for folks who, no matter, there is not a certain diagnosis that exist that would automatically assume that the person does not have the capacity. So unless you have a court document saying otherwise, you should be assuming competence with folks and trying to communicate directly with that individual. And also trusting their lived experience. I know that, and I've experienced this as a person with a psychiatric disability, but a lot of times medical providers can shoot down what you know to be true about your own body and your own experience and how you may react to certain medications or things like that. And it's really important to know that this person has been living with this disability and they do have some information that would be valuable to that. So having a shared decision-making process between the medical expert and the person with the disability is important. Supported decision-making. This is one of my passion areas. But it is really important to accept that some people with disabilities may have a support network and they may want them to be involved. And so they may not be able to understand complex medical information, but they may have someone trusted on their team, a family member or a friend or a neighbor who they want to be with them at medical visits to help them understand what their choices are and help them weigh the pros and cons so that they can make the best decision for them. And so allowing for supported decision making to be a part of your medical practice. Thinking about community support. So what resources may be available in the community to them? Should they apply for a Medicaid home and community-based service waiver? Are there certain support groups or peer advocacy groups that they may want to be involved with that would help them in the community? Thinking about what's out there and having your staff have some awareness of what these services that are available could do for them and making sure that they're connected, because it's not all about what happens in that medical office, but how they take that into the community and live their day-to-day lives, because that's where they're going to be spending more time. There may be a center for independent living that is nearby that can teach them some independent living skills, especially if this diagnoses is something that maybe they are transitioning from their parental home. They're a youth and they're transitioning into their own apartment and they don't know how to cook yet. So there may be some cooking classes or an independent living center that can help teach them some of those skills. Thinking about what that caregiver support looks like. Do they need to know about respite services that are available? Do they need to be connected to a peer network? Really respecting their privacy, giving them the respect that you would give to any other patient, giving them the dignity to say who can be in the room and who doesn't. Just thinking through all of those things and treating them as you would any other patient. Next slide, please. Okay, so we're going to talk about what the tool looks like now. This is just a preview. So this is the instruction page of the tool. It is in an Excel format. And so there are instructions over each column that tell you just a little bit about the tool. But if you look down to the bottom row, it gives an example of one of the questions. So this one says the category is scheduling. And the question is, do you offer an online option to schedule an appointment? And that's in addition to calling the office to schedule. And then next to it is a column that allows us to select what level of effort we think this would be for a provider. We think that the effort level for this would be modest if you don't already have it. And then the effort levels are minimal, modest, moderate, and legally required. And so we tried to estimate it. It may be different depending on your situation, but we tried to estimate what we thought. And then the provider who's taking this audit would be able to mark for themselves whether yes, this is something you do, no, this is something that you don't do, or this it really isn't relevant to my practice. And so I'm just going to put not applicable. And then they can fill out comments so that they can put a little more detail about the answer to that question that may be helpful when they return to the results later. And then the last column is a time frame to address it. And so when looking at this, a provider would want to think through whether this is on their radar. It may not even be something they want to address right now. If they select within 6 months, they can select within 1 year, or 3 to 5 years, or not a priority. Based on what you select on that tool, it will automatically populate into an action plan tab. There's a short-term action plan tab, a medium-term action plan tab, and a long-term action plan tab. You can change the time frame at any time in this audit tool, and it will change where it appears in the action plan. So nothing, you don't have to be stuck with whatever answer you put, but this will help you get started on an action plan. And then you can also see at the bottom the different domains that we talked about. And so you would go from tab to tab to answer those questions when you're doing that self-audit. You don't have to go in order, and one person from your team does not have to do the whole self-audit, but it does need to be folks who would have those answers. So typically it's higher level staff members, or it could be the person who wrote your policies and procedure manual, or who is most familiar with it, the person who is over the staff training. So it's up to you to decide how many folks to bring in to do the audit. We think the best strategy, if you have the staffing and capacity to do so, is to divide it and to have an audit team. And again, because this is a self-audit, there's no deadline or due date on how long this should take. This is for you to do at your own pace. Our goal was that this audit tool can serve you for years and years to come. So you may do an audit now, and then you may want to do it again in 2 years to see where you've come, how far you've come, and to celebrate some of those successes. But we think however you choose to do it, it's best to share the results with your team and share what your goals are for your action plan so that you can all be on the same page and take some ownership of what that should look like. Next slide, please. So you can see here what the short-term action plan tab looks like. So in this case, they had put that they would wanted to address it within 6 months, and so it automatically would show up in this tab. And all of the questions that they selected would be here. In this case, there's just one because we just did this for demonstration purposes. But this one was, are your forms written in plain language? And they wanted to tackle this one right away because this one is a low cost solution that could really impact folks. For how will we address, that's an open-ended response. So you can put your notes in there of how you plan to address it. You can put the staff member that is responsible for addressing it. And then you can put any comments in there that you think may be important to remember when you're addressing it. And then there's in progress, not started, or completed, and you can select those to track your progress. All right, next slide, please. So that's the overview of the tool. I do want to just talk about a few just getting started resources that I think are super helpful for folks. So I just selected a few to not overwhelm. And these are all in the companion guide that are going to be coming with the tool too, but I wanted to go ahead and give these out. One is one developed by Katie's region that our moderator for today, and that is the ADA and Health Care webinar series that was developed by the Northwest ADA Center and the Oregon Health Authority. I think those modules are really great and a great primer for folks. There's one about physical access, and it's called Modernizing Healthcare to Improve Physical Accessibility, a primer for providers. And then there are two under the operations domain. One is about informed consent in adults with intellectual and developmental disabilities. So it really talks through what informed consent should look like and thinking through how you want your policies and procedures to look. And then the other one is communicate care, and care is in all caps. And that's really an overview on how to communicate with a patient that really makes them feel understood and listened to, and it's really all about that patient-centered care. So I think that one's important to highlight as well. Okay, I'm seeing lots of great things in the chat, so I can't wait for the Q&A portion. But for now, I think it is time to go on to the next slide and switch it back over to Brenda.
So, as part of our discovery on this project, we learned that there was a lot of issues and challenges that were shared with us from people with intellectual and developmental disabilities, as well as caregivers, and in some cases, there are some that were noted by providers. So, among these systemic and structural challenges was fragmented care coordination across providers and services. This is an area in which, there's lots of potential to be able to bridge gaps when it comes to trying to make sure that patients get referred in a timely fashion, that there's follow-up, that there's coordination. So there's lots of possibilities there for how improvements can be made. Then there's the insurance and reimbursement policies that don't incentivize accommodations. That's a little bit of a tougher nut to crack, but there is an opportunity to work more strategically in that area. Long waits and scarcity of specialized providers, as Jerry mentioned, and I think I've seen it in the chat, that this is often a problem, a major problem, especially folks that are on the waiver waiting list. And sometimes their wait time has been not just a couple of weeks or months, sometimes it has been years. Because of the lack of trained providers or providers who do not feel comfortable providing care to this population. Some of that might be due also because they need a um, longer time to be able to treat patients, and they're not receiving the same type of reimbursement for those extended appointments. So that creates a bit of a tug in terms of who's willing to do what and when for some providers. Then there are other providers who are very compassionate and are and welcome the ability to provide services and care to this population. Then there's the lack of accessible transportation to appointments. And I think on the slide that I shared about some of the conditions in the social model, that's one of them, transportation. Next slide. So we had adopted an inclusive approach to the development of the self-audit tool by partnering with stakeholders. And Jerry mentioned that we had invited participants to be in focus groups, and we had also surveys that they were able to provide to responses to, and then we also interviewed various stakeholders, and I guess the point that I want to make here is that we embrace the disability community's mantra, nothing about us without us. I mean, we wanted to know what the impacts were or implications were for people with lived experience. It's hard to fix something if you don't have a good handle of what the real issues are, the root causes of them. So it was very critical that everybody be brought to the table, have an equitable voice in sharing what some of the priorities were for them. So they were also involved in co-designing of tools and their implementation. We had inclusive testing and feedback loops, and we adopted a process that ensured the tools reflected lived experiences and that built trust, ensured relevance, and informed usability. Next slide. So what is our vision for the future? That healthcare services are accessible for all patients, regardless of disability, that they are equitable so that they reduce disparities in care, that they are inclusive, that patient voices are included to drive universal and disability design principles, and importantly, that they're effective, that they're data-driven to support continuous quality improvement. Next slide. Just to touch on the universal design versus inclusive design versus accessible design, my perspective is if we adopted universal design on the front end, it would be much more cost effective to do that when and not have to go back and make adaptations. Inclusive design actually considers the full range of human diversity and addresses all needs, but accessible design meets the needs of people with disabilities. And again, I'm a proponent of universal design because then that way, if you make the accommodations on the front end, again, it's very cost effective to do that than trying to go back and retrofit different types of modifications. And this is not just on the physical space, but it's also on all the aspects, how we communicate information. It's not just that people with intellectual and developmental disabilities have challenges understanding that. There are some members of the general population who, when they go to the doctor, they need to have supportive, so they need to engage their support decision makers from their networks to help them digest some of the medical information because quite often there's a lot of jargon that is misunderstood or needs to be broken down. And so I think that, again, I am just a proponent of universal design. Do it at the outset, and we can definitely make sure that it fits and can be used by all. No adaptation would be needed. Next slide. So there are plenty of opportunities for providers. First of all, they can adopt person-centered approaches. This will help to take care of and prioritize patient needs, preferences, and values. Engage in active listening so that you hear and comprehend what the patient is sharing with you about what their needs, preferences, and values are. Advocate for inclusivity and fight against discrimination. Really critical. It happens that, in certain environments, exclusivity is rampant and discrimination is rampant. We need to abandon those types of behaviors. Respect the needs for autonomy and self-determination. Because again, there's a lot of stigma associated with this population group, and it doesn't mean that they can't understand something. Jerry mentioned that you shouldn't assume that they're incompetent unless there is some kind of court documentation that says they're not. So you should treat them with respect and allow them to participate in the decision making and make sure that the information that you're sharing with them is accessible. Consider the rights in decision making. They have rights just like everybody else has rights. We just need to make sure that the rights are recognized and that we are addressing them. Next slide. We're at the question point. Sheriff?
Yeah, and I just so everybody's aware, there's just some funder language that we're required to put on that slide, so that's there. And then there's an email address that is info@centerondisability.org, just if there is something that doesn't get covered today that you that you have questions about or want to share. I also want to say a lot of you all have shared resources in the chat. What I think might be best to do with that is we will download the chat and look through those resources. And when we send out an email with the tool, we'll also put any links that we think could be helpful, because there are so many resources out there. So we want to make sure that we're providing you with stuff that's helpful and relevant. So we'll be happy to do that.
This is Katie, your moderator today, and so I want to start asking our presenters some of the questions that people have put in the chat already. So everyone, please feel free to keep giving us more questions. The first one I want to start with is pretty concrete. So as part of developing this toolkit, you looked at the research that already exists, and so we call that a literature review, kind of figuring out what science has already told us about this issue. And someone wanted to know, is that published anywhere? Can people find that information that you collected?
Brenda, I know that we put the literature review and the report that we provided to the Special Olympics folks. I don't think that they are making that report public, but I can double check. Also, if someone has a special interest in that and what we looked at, then I think we could probably send that your way. So you can email that email address down below, and we will send it your way. But I don't think that the report is public, but if it is, we'll share that along with the link to the tool.
Okay.
And I really credit Brenda, sorry, with all of the digging through the research. So
So we've got a couple of questions in the chat that are about, right, the lack of training, that providers don't have training on providing accommodations or kind of knowing what the ADA requires. And so one of the questions is, in your research, did you come across great programs where healthcare providers were being trained to kind of to think about the social model of disability or to provide accommodations as a regular part of their practice? So any great examples of programs where they're doing it really well?
So if I go ahead, Jerry.
no, you go ahead.
If I could just say that, yes, we did find some that were exemplary programs. Some of them are online, and I don't want to misquote any of them, so I'm not going to say any of them. But yes, there are. Yes, there are. If you write to us, if you write to the email address that's on the screen, that I'm sure that we could pull out some of the ones that we could direct you to. But yes, there are some, and one that I'm thinking about is university-based. Actually, a couple of them are university-based programs. So I would definitely want to share those.
Thank you.
And I would just go ahead.
I'm sorry. I just want to add one more thing, that there are lots of national organizations that are also working on this area to try to push health policy around this, and to use that as a strategic approach for ensuring that providers get adequate training for this population group. So there's a lot of recognition that there are gaps there, and that there is a lot of effort being undertaken to try to address some of those gaps. That's it.
Yeah, and I was just going to say that what we mostly saw were folks that had been trained on the job by providers who were trying to do a better job with that. That was more common, but also some of those providers had taken to partnering with universities to give folks an internship there, or to develop in the case of the Jefferson Fab Center, they had developed a curriculum that they partnered with and with the university, and we're doing too. So it's definitely a need, and that was, yeah, absolutely a common theme.
Thank you both. One other kind of, it's people shared comments, but it came up a few times, so I want to ask for your thoughts about this, that people talked about either their own lived experience or the lived experience of a family member going to a provider and having their kind of needs or their words be dismissed, or even just being treated kind of as if, oh, you're a patient that we don't really want to serve. And that came up a couple times in our chat during the webinar. And I wondered if you had any thoughts about, I don't know, kind of how that could be addressed in training, or if that's kind of something that's noted in the toolkit, that are you checking for whether or not that comes across in your interactions with patients?
Yes, I think that that was a very common theme, and one of these reasons why these specialty providers exist, and they didn't, they didn't necessarily want to be specialty providers just for this population, but they knew that there was a huge gap in providers who did feel comfortable, and I think a lot of it is just a misunderstanding or a lack of education and training to feel confident serving this population. I think that is a very common thing. And that's hopefully something that the toolkit will help make more approachable. But yes, and again, too, you are not supposed to turn away a patient just because of their disability, and that could bring some ramifications on the legal front. So it's really something that everybody has to do, and so you need to get trained, and you need to make sure you feel comfortable doing that. But the lack of access was very much a common theme, and I think that's why Brenda's stuff about patient-centered care and just thinking through how to make someone feel accepted and welcomed is really important. Brenda, I don't know if there's more you want to add on that.
And I think you've covered it because I think that's critical. I would also add the reimbursement is also a factor that kind of influences, I think, to some extent with some providers, their willingness to serve this population group.
Absolutely.
Well, Brenda, that kind of leads me to my next question. Someone just wanted to know more about that topic, that kind of what states provide adequate reimbursement, and are there kind of differences or best practices around this that you all encountered too?
Well, there is a lot of variation in terms of what states do.
Yeah.
So could not begin to say because we didn't study that in that way. We didn't survey all of the states in essence to find out what was the difference or what were the commonalities. That's a good study. You want to join us in doing that? Whoever asked.
We're also that is something that was definitely a theme, and has piqued Brenda and my interest, and we want to dive deeper on the advocacy side of things and the systemic barriers. It was beyond the scope of this project just because this was a self-audit tool for medical providers, but not only with just typical medical visits, but dental access as well was a huge thing too.
Well, let me ask a broader question. So someone asked, just do you have things that you think should be included in the training that I think they asked kind of general medical and nursing education? What are some highlights that should be in that training for healthcare providers?
So in the staff training section, we we ask all the questions about the training, and then in the companion guide, we list what resources. We try to do a resource at least for each question. So there are a lot. There's a chart there that says what question it addresses, and there are trainings available, and so I think that's a good start for folks. I think really for if we're talking about before you're out of school and into the medical profession, then there just needs to be more time on the curriculum devoted to disabilities in general, but then specific to the IDD population. And I think communication should be a huge part of that. Informed consent and decision making should be a big part of that as well. What I would love to do for a next phase, and I've talked with Katie and some of the other ADA directors who are on the healthcare committee about this, is creating a model curriculum that we are able to share and then to get it. Right now, it's very diverse from school to school on what you learn when you are a student, but trying to get some uniformity there in what folks are learning about disability.
Okay, one more question is about it's a really interesting one. It's about whether or not in this process you came across any tools to help families think about autonomy or decision making differently, right? And so um, we have some very kind of old-fashioned ways of thinking about what it means to have the capacity to make a decision, and can take some work to change our minds and to be more open to a broader view of capacity. And you talked about teaching about, assuming that someone has competence. So are there any tools, kind of someone's interested specifically to help families think about competence differently?
Sure. In my previous job, I actually co-created a tool about this, and it was targeted more for transitioning youth. So thinking about that when someone is younger, but I think the same could apply for an adult, especially if they haven't really been exposed to those opportunities. But it looks at whether a person has had an opportunity to practice skills in various areas of life. So whether they have had the opportunity to practice um, with finances. And again, it breaks it down to different tasks that you could do to practice financial independence. And then there are stuff with taking care of a home or other topics. And it's been years, but those is it's an easy to fill out tool, and the person with the intellectual and developmental disability can fill it out. A caregiver can also fill it out, so you can kind of compare notes on what the person thinks that they've had the opportunity to learn or not learn, what the caregiver has what thinks, and then maybe also a teacher or a service provider can fill it out too, and you can all kind of compare notes and see what opportunities that you can offer, because really it's about practice. All of us learned the skills that we learned to be independent through trial and error. We were all given those opportunities, and someone either taught us or we had to learn by failing and learning again. And so it really is about making a plan. I think it has to be a little more intentional with this population, because our tendency is to protect from harm and to protect them from making mistakes. But really, that is a way to learn, and it's a valid way to learn. And so we need to do that, and we can do that in ways that are safe and allow them to practice those skills until they're able to do those on their own. Yes, somebody posted in the chat, dignity of risk. Absolutely, we all have that, and I think that often parents, well-meaning, can take some of that away from folks with intellectual and developmental disabilities, and so it's really important to give those opportunities early and often.
Thank you, Jerry. So one other kind of question was about kind of how this toolkit, or kind of whether or not this topic, kind of how could it apply when people speak diverse languages, right? So I think, Jerry, you had mentioned an example of Spanish, if someone is a Spanish speaker, and that this toolkit might have relevance in that context. So could you talk to us, Jerry and Brenda, about how this could help, or how this toolkit could be useful to people with IDD and diverse languages backgrounds?
Yeah, and I think that is, if you're having trouble finding a qualified provider who you feel is competent in serving people with intellectual and developmental disabilities, then that is even more narrow for someone who is trying to find someone who is competent in providing services to someone with IDD and speaks another language. So it is a big barrier for folks, and that's something that I think we could do better on. We talk about plain language and easy read a lot because I think that is a tool that applies to multiple different audiences. But again, that does imply a basic understanding of the English language. But I think that it's important to provide that language access, and it's required to provide that language access for appointments too, and not relying on a caregiver or family member. We have seen a lot of stories of medical providers not wanting to pay for the translator and instead using a family member, and it's just not that is not the same quality of service, and they are not getting pertinent information. And in the medical setting, that's really important. And so it's really important to do. And so it might be worth doing some research to make sure that you have translators who feel comfortable in serving that population or trained in serving that population. But I think a lot of us, myself included, could improve on the way we communicate in general so that when it's translated, that makes it even easier to translate. And there's stuff out there that shows if you're putting stuff in plain language to begin with, then the translation is going to be much more accurate when you do translate that to another language. So that's just best practice in general. Brenda, do you want to add anything to that?
No, I think you've covered it. I don't have anything else to add.
So I have a kind of more specific question about how you tested and developed the toolkit. So someone wanted to know if any dental offices participated in that process.
Brenda, I know that we had we had some key informant interviews that were dental providers, and we got their feedback. Um, I'm trying to think. I don't think any of the pilot sites were dental providers, but we did spend a lot of time with a couple of folks. Delta Dental Foundation connected us with some folks that they had worked with who were doing a really good job of serving individuals with IDD, and talked to us about some of their best practices. And so we were able to get some information there. Um, the dental stuff is really, it became a big trend, and what we were seeing, the lack of dental access was even further beyond the lack of quality medical services. And so Brenda and I are desperately looking for how we can work on another project that's specifically about dental access for people with IDD. So hopefully you'll be seeing more from that in the future.
Okay, well, let me go to a question about advanced directives. So you mentioned, right, that I hadn't really thought about this, the importance of teaching healthcare providers and their staff, their entire staff, about guardianship, power of attorney, supported decision making, that they need to be able to read these legal documents in order to know, right, what someone's rights are. And someone just asked, is this kind of, do you have experience around advanced directives? Is this something that you might also include in a training to staff?
Yes, I love that question because I think we need to be thinking about people with IDD from birth to end of life. And I think that advanced directives can be a scary topic to approach with some folks in that population. And I saw this come up actually a lot during the height of COVID, where people with intellectual disabilities were in hospitals because they had contracted COVID and their support network was not allowed to be there with them. And they were on respirators, or they were preparing for end of life decisions, and no one had ever talked with them about that before. And so we had physicians calling, asking, what do I do? Are there resources out there? And so I think it is very important to start those planning tools early. I do think that there are some close to plain language resources out there. It's been a while since I've looked at that. But if you want to send an email to me so I don't forget, I'm happy to go digging for that again. But it's something that we all need to think about. And I think medical providers need to be approaching that topic with with all of their patients, but particularly I think people with IDD need to be prepared in advance to think about what they want their healthcare to look like in the future.
And I would like to add that I agree with everything that Jerry just said. I would offer that there should also be some ethicists that are engaged in those discussions because how things were, the decision making during COVID raised a lot of concerns in certain areas as it relates to prioritizing who got equipment, just the whole care process. And so I would like to see us do more work in that area. I think it definitely is an area that needs to be integrated into the medical school curriculum because it shouldn't just come up after one goes into practice. It needs to be something that is thought about, that is discussed, taught, all of that early on, and I guess I should say, and that's my opinion about it.
I know, I think that's very important is and this is a population that can be potentially exploited or taken advantage of, as are other people with disabilities or folks who are speak a different language. And so it's really important to think about those things before they're in a high pressure environment where resources may be scarce, and that way that stuff is already documented. It's just another form of protection.
Mhm.
Well, Jerry, I think this question is for you because it's sort of a what does the ADA require in this situation? And so
Okay.
someone asked, what do you recommend for dental services for people who cannot transfer to a dental chair? And so I'm
Yes.
assuming that the question might be that someone who's a wheelchair user and can't independently transfer to a dental chair, what's recommended or required here?
Yes. And Katie, you jump in too, because I know this is your area of expertise. So there are some new stuff out there about medical equipment and what's required. We are hopefully moving toward an environment where we are thinking more about universal design and getting equipment that makes it easier for folks to get into a chair or a table that's easier. I really do think that staff need to be trained on how to assist in transferring. That's a basic part of what a lot of folks would need to be able to get to access the medical services. And so that would be an accommodation or modification that you could provide while they're are visiting your office. And so it's something that you need to think ahead about and be prepared for. And there's lots of equipment that are out there, like a Hoyo lift, that can make that safer for staff to use. Katie, anything that you want to add to that?
I think I would share that if you go to ada.gov, which is the Department of Justice's Americans with Disabilities Act website, they have a great guidance document. It's called Access to Medical Care for People with Mobility Disabilities. And so they give tips on, right, like Jerry said, training staff to be able to assist with transfers, ensuring that you do have accessible medical equipment when it's required, and that there are times when it might be appropriate to provide services to someone when they are in their wheelchair, but there are other times when that's not appropriate, right? So it really depends on the kind of medical procedure that someone's getting treatment for.
Yeah,
Yeah,
thank you
I
for
always like to
sharing that.
plug
And yeah, and
ADA.gov.
will you make sure we put that resource
Yeah,
in the chat as well so that
yeah.
that doesn't get left off of our email? I appreciate that.
Okay, well, I think that's the end of our questions, and wow, we only have 2 minutes left.
Will you move to the next slide, Gabe? I just wanted to let you know that we're going to be sharing the resource via email, but we'll also be sharing stuff on our social media. So feel free to join in there, especially as Brenda and I try to conquer conquer other related topics that you all brought up in the chat.
Okay, so this is Katie again. I'll kind of finish us off with some more information. So if you still have questions for our speakers, and I think quite a few people had very specific questions, that'd be great if you followed up over email so Jerry and Brenda could share resources with you individually. So if you still have questions though, you can reach out to your regional ADA center, and we help people try and understand um, how the ADA applies in a specific situation. And so that phone number is 1-800-949 and 4232. So afterwards, you'll receive an email with a link to an online session evaluation, and we would really appreciate your feedback and input. So please complete that. So last, I just want to thank our speakers today for sharing their time and knowledge with us. It was a great session. I know I learned a lot. And I also want to thank everyone, all of our participants, for attending today's session. Thanks for learning with us.
Thanks, everyone.
Thank you.